Good evening, Dr. Phil here. Today we'll be discussing on conduct of anesthesia for patients with a transplanted heart. Physiology of the denervated heart. Kindly refer to the video on the physiology of the denervated heart for further details. Preoperative assessment. Around 5,000 to 10,000 heart transplantations are performed annually worldwide, and this number is expected to increase. First, assess the cardiac functional status and any symptoms or signs of heart failure. Identify the indication for the previous heart transplantation and the current surgery and manage associated complications if present. Indications for heart transplantation includes ischemic coronary artery disease 39.5%, non-ischemic cardiomyopathy 49.5%, valvular heart disease 2.4%, retransplant 2.3%, congenital heart disease 2.4%, and miscellaneous 3.8%. Indications for surgery or anesthesia post-cardiac transplantation can be divided into heart transplant and non-heart transplant related. For heart transplant related indications, this includes complications of diagnostic procedures such as endomyocardial biopsy with right ventricular perforation, pneumothorax and hemothorax, complications of transplant surgery such as bleeding and allograft vasculopathy, complications related to immunosuppressive therapies such as cancer and cholelithiasis, and venous thromboembolism requiring embolectomy. Non-heart transplant related indications includes aortic aneurysm repair, laparoscopy, pregnancy and labor, fractures and dislocations, other organ transplants, etc. Ensure adequate preload and intravascular volume as these patients are preload dependent. Identify and address issues associated with heart transplant patients such as denervated heart, allograft rejection, infection due to immunosuppression, drug interactions, allograft coronary artery disease, hypertension, and renal dysfunction. Allograft rejection. This typically occurs in the first 6 months post-cardiac transplant and presents with fever, malaise, arrhythmias, dyspnea, unexplained weight gain, edema, heart failure, and cardiogenic shock. Urgent endocardial biopsy is required to confirm the diagnosis. A negative biopsy does not exclude allograft rejection. Treatment. Patients who present for surgery with signs of acute rejection may benefit from delay of surgery to optimize their status to avoid increased risk of morbidity and mortality. Emergency management involves increased immunosuppression by using IV immunoglobulin, plasmapheresis, and other immunosuppressants. The patient may need mechanical circulatory support. Identify and treat complications caused by immunosuppression by drugs such as cyclosporin A, azathioprine, anti-lymphocyte globulin, monoclonal antibodies and corticosteroids, tacrolimus, and mycophenolate. Infections. Immune reactivity decreases with time, therefore immunosuppressant dose regimens are highest in the early months following transplantation. However, immunosuppressive drugs are continued indefinitely in heart transplant patients. Examples of infection of concern includes early post-operative bacterial infections such as mediastinitis, opportunistic infections such as CMV, pneumocystis carinii and toxoplasma, and fungal infections, which may need prolonged treatment. Infection is a major cause of death. 10% of mortality 5 years post-transplant is due to non-CMV infections. Any infection should be treated preoperatively as soon as possible. Immunocompromised patients may not present with typical signs and symptoms of infection, such as fever and leukocytosis. Thus, a high index of suspicion is essential, and microbiological tests are required to rule out the diagnosis. The types of infection to which transplant recipients are susceptible changes over time. Consider consulting infectious disease specialists for preoperative transplant patients. Other complications of immunosuppressive drugs. For the CNS, lower seizure threshold, polyneuropathy and encephalopathy, CVS, hypertension, hyperlipidemia, atherosclerosis and anaphylaxis, renal and electrolytes, renal failure, hyperkalemia and hypomagnesemia, hematologic, increased risk of malignancy, pancytopenia and infections, gastrointestinal system, GI ulcerations, hepatitis C recurrence, cholelithiasis and pancreatitis, endocrine and others, such as diabetes, osteoporosis, poor wound healing, weight gain, Cushing syndrome, and drug interactions. Dose adjustments for some drugs as well as adjuvants may be needed. Cardiac allograft vasculopathy. This is an accelerated process of coronary atherosclerosis due to chronic rejection, characterized by concentric intimal proliferation and diffuse narrowing along coronary vessels. Allograft coronary vasculopathy is the greatest threat to long-term survival post-cardiac transplant. 10 to 20% of patients within the first year of transplantation develop CAV. 44% of patients develop CAV between the first and 10th year post-transplant. Etiology, immune and non-immune factors are involved, such as immune-mediated vascular injury, ischemic endocardial injury before transplant, immunosuppressive agents, CMV infection, hyperlipidemia, smoking and hypertension. Risk factors include donor hypertension, induction therapy with IL-2 antagonist or OKT3, pre-transplant coronary disease, clinical infection in the donor, older donor age, and decreasing recipient age. Heart failure, arrhythmias, and myocardial ischemia may occur. However, there will be absence of warning symptoms of angina pectoris in the denervated heart. Diagnosis is via coronary angiography and intravascular ultrasound, which is the most sensitive technique to detect early changes. Post-transplant hypertension. 97% of surviving patients develop hypertension after 10 years post-transplant. Etiology, cyclosporine. Treatment, ACE inhibitor. Diltiazem may increase cyclosporine serum levels, and nifedipine can cause significant vasodilation and may be tolerated poorly in these patients. Beta blockers are often avoided as cardiac responsiveness during exercise is dependent on circulating catecholamines. Post-transplant renal dysfunction. Renal dysfunction is present in 31% of recipients 5 years post-transplant and is due to the nephrotoxic effects of immunosuppressants such as cyclosporine. Serum creatinine generally plateaus around 170 to 180 millimoles per liter. Avoid nephrotoxic drugs during anesthesia, such as amphotericin, chlorotrimazole, cimetidine, vancomycin, ranitidine, tobramycin, mephalan, gentamicin, and NSAIDs. Avoid anesthetic drugs that are excreted mainly via renal clearance. If they are used, dose adjustments may be necessary. Post-cardiac transplant arrhythmias. Many have heart blocks due to biatrial anastomosis, organ rejection, nodal ischemia, and inadequate myocardial preservation. About 25% of patients develop bradycardia that will require implantation of a permanent pacemaker. Implanted mechanical pacemakers work normally in heart transplant recipients. This is because the cardiac leads are placed directly into the myocardium. Significant atrial and ventricular arrhythmias are infrequent, however ectopic beats are common. Fatal ventricular arrhythmias typically indicate severe acute rejection or allograft coronary artery disease. Antibiotic, antiviral, antifungal, and immune suppression regimens should be disrupted as little as possible in the perioperative period to reduce the risk of rejection or infection. Daily monitoring of steady-state blood levels of immunosuppressants are recommended. Oral cyclosporine should be administered 4 to 7 hours before surgery to maintain therapeutic blood levels. Changes of the dose of other immunosuppressive drugs is not required unless the route of administration needs to be changed from oral to IV. Supplemental steroids are not required for stress coverage except in post-transplant recipients in whom steroids are recently withdrawn. Consult the cardiac transplant team for further instructions. Ambulatory surgery for heart transplant patients. There is a lack of evidence supporting either the safety or harm of ambulatory surgery in heart transplant patients. There is a lack of data that details selection criteria or outcome in heart transplant recipients subjected to outpatient surgery. The choice of anesthetic technique seems to have no influence on outcome. Management. Pre-admission clinic preoperative assessment with appropriate screening tests. Evaluation by the Cardiology Transplant Service for further tests and plans for perioperative antibiotic prophylaxis and immunosuppression. Patient selection for ambulatory surgery proceeded based on local guidelines. Important investigations. All heart transplant patients should be evaluated with ECG and transthoracic echocardiogram prior to surgery. New findings should be discussed with the cardiology consultant to determine the need for stress test or myocardial biopsy. ECG. Expect a resting heart rate of 90 to 110 beats per minute. The ECG may show two P waves. One P wave originates from the native atrium and the other from the implanted atrium. Do not confuse the native P wave with complete heart block. Signs of ischemia may be present. Arrhythmias may be detected. First-degree AV block and dual AV nodal pathways are common. Re-entry dysarrhythmias are rare. If bradycardia is present, these patients should be treated with a direct-acting beta agonist such as isoproterenol and adrenaline. Medications such as calcium channel blockers and beta blockers, which may be used to treat tachyarrhythmias, need to be used with caution due to their negative inotropic effects. Other tests include transthoracic echocardiogram, cardiac stress test, endomyocardial biopsy to rule out allograft rejection, coronary angiography and coronary intravascular ultrasound for patients with suspected allograft vasculopathy, and other investigations as indicated such as full blood count to rule out pancytopenia, serum electrolytes and renal function tests, liver function tests, blood glucose, etc. Intraoperative management. Mode of anesthesia. Regional and general anesthetic techniques have been used successfully in post-transplant patients. No technique has been demonstrated to be superior as long as preload is adequate. However, general anesthesia is preferred by many over regional anesthetics. This is because the denervated heart does not reflexively compensate for hemodynamic changes induced by use of regional anesthesia. Monitoring. These patients have similar monitoring requirements as for non-transplant patients undergoing similar procedures such as ECG, NIBP, capnometer, SpO2, temperature probe, multi-gas analyzer, and neuromuscular blockade monitoring. Careful preoperative assessment may reduce the need for invasive monitoring with all its associated risks. Invasive monitoring when warranted by clinical status and surgical procedure, such as for cases with potential for significant blood loss and fluid shifts, to help manage fluid administration and inotropic support. These include intra-arterial blood pressure monitoring, central venous pressure, pulmonary artery catheter, and invasive cardiac output monitoring such as esophageal Doppler and arterial pulse wave cardiac output monitoring. Apply measures to reduce the risk of infections as these patients are immunocompromised. Orotracheal intubation is preferred over nasotracheal intubation as the latter is associated with infections by diphtheroids and staphylococcal organisms from the nasopharynx and the skin. All forms of instrumentation and invasive monitoring techniques should be kept to a minimum adequate to achieve safe anesthesia. Earliest removal of invasive lines are mandatory. Maintain sterility for all procedures and techniques as the patients are immunosuppressed. These patients should receive CMV negative blood transfusion. Airway and ventilation issues. Orotracheal intubation is preferred over nasotracheal intubation as mentioned. Gingival hyperplasia is present occasionally in patients taking cyclosporine, and this may lead to bleeding and aspiration during airway manipulation. Sympathetic and parasympathetic hemodynamic responses to laryngoscopy and intubation are absent. Difficult airway may be encountered in patients with diabetes and lymphoproliferative disorders. Laryngeal mask airways may be used if there are no contraindications. Avoid hyperventilation in patients taking cyclosporine and tacrolimus to avoid seizures as there is a decrease in seizure threshold with patients taking these two drugs. Drugs of choice for altering cardiac physiology after heart transplantations are drugs acting directly on the heart. Examples of these drugs include isoproterenol, which is a mainstay of chronotropic therapy to increase the heart rate of cardiac transplant recipients, dobutamine, adrenaline, which is reserved for refractory cardiogenic shock, along with noradrenaline and glucagon. Resting inotropic state and myocardial blood flow at rest is usually normal, Effects from beta agonism versus alpha agonism are exaggerated in heart transplant recipients due to upregulation of beta adrenoceptors. The increase in blood pressure from these agents does not lead to a reflex bradycardia via the baroreceptor reflex. Drugs that act indirectly on the heart via either sympathetic or parasympathetic nervous systems are ineffective. Examples of these drugs include antimuscarinics such as atropine, anticholinesterases such as neostigmine, pancuronium, digoxin, and ephedrine. Ephedrine has direct and indirect agonist effects on alpha and beta receptors. It is less effective as only its direct actions will alter heart rate and thus it is best avoided. Instead of atropine, treating bradycardia will have to be done using directly acting drugs as mentioned above. The denervated heart does not respond to peripheral stimuli that induce hemodynamic changes such as carotid massage, laryngoscopy, or Valsalva maneuvers. Drug interactions. Patients on chronic steroid treatment should receive perioperative steroid coverage if steroids are recently withdrawn. Larger doses of competitive neuromuscular blocking drugs may be required if the patient is receiving azathioprine. Azathioprine antagonizes competitive neuromuscular blocking drugs by its phosphodiesterase inhibiting properties. Cyclosporine potentiates the neuromuscular blocking effects of atracurium and vecuronium and increases the duration of actions of barbiturates and narcotics. NSAIDs should be avoided to avoid exacerbating underlying renal dysfunction related to immunosuppressive agents and to reduce the risk of gastrointestinal hemorrhage amongst patients on chronic steroids. This table lists the common drug interactions encountered by the anesthetist. For isoflurane, the clearance of oral cyclosporine decreases with isoflurane anesthesia and a steady state level of cyclosporine is maintained with IV cyclosporine. Most of the inhalational anesthetic agents are well tolerated unless there is significant heart failure. Thiopenton, propofol, and etomidate does not have significant interactions with immunosuppressants. There might be an increase in blood levels of benzodiazepines and dose modification is required if the patient is receiving immunosuppressants. Most of the muscle relaxants can be used safely. Atracurium and cisatracurium are preferred as their elimination are not affected by renal or hepatic function. Neostigmine usually has no effect on the transplanted heart. However, in re-innervated hearts, bradycardia and asystole may occur. Cyclosporine increases the opioid effects of fentanyl and morphine. Bupivacaine can be safely used through regional routes without any side effects. Lidocaine's half-life is increased by cyclosporine. Analgesia. The denervated heart has a blunted sympathetic response to inadequate anesthetic depth or analgesia. NSAIDs should be avoided for the above-mentioned reasons. Laparoscopic surgery. Pneumoperitoneum is usually well tolerated. The hypertensive response to pneumoperitoneum, if present, can be treated by an increase in analgesic dose. Neuromuscular blockade reversal. Neostigmine may produce bradycardia. A muscarinic antagonist should be administered simultaneously with neostigmine to block these muscarinic side effects. Postoperative care. Routine care as for non-transplant recipients. Additionally, increase attention to optimizing preload status, renal function, and prevention of infection. Large intraoperative fluid shifts can cause acute decrease in cyclosporine or tacrolimus blood levels. The immunosuppressants should be continued post-operatively and blood level monitored in the ward. Pregnancy and delivery. Immunosuppressants can be continued during pregnancy unless they are teratogenic. Currently used immunosuppressants are typically not teratogenic. There is an increased risk for developing preeclampsia, eclampsia, premature labor, and allograft rejection. No matter the mode of anesthesia, aim to maintain hemodynamic stability. Strict maintenance of preload is mandatory. Avoid too much IV fluids as this can lead to heart failure. Phenylephrine is the vasoconstrictor of choice. For neuraxial blocks, it is preferred by many anesthetists because it produces less impact on the baby compared to general anesthesia. Aim to provide an appropriate block level. Too high a level of block may cause vasodilation and hypotension from sympathetic blockade, which is unfavorable for a transplanted heart. Too low a level is not suitable for surgery, and the resultant pain may lead to increased myocardial oxygen consumption and precipitate myocardial infarction. Strict asepsis and antibiotic prophylaxis should be used for all operative and instrumental delivery. Immunosuppressants should be continued post-operatively. These are my references. Thank you.